Good morning. I want to thank the organizers for inviting me. It's a real pleasure to be here and to get to tell you a little bit about some of our work. So I'm an attending neurosurgeon at Brigham and Women's. My specialty is in the treatment of patients with brain tumors, which is what you're watching here. It is the kind of thing where you are constantly weighing the risks and benefits of what you're doing every step of the way, trying to maximize the benefit and reduce the harm. And the more information that we have in our hands before going in, the better we can do that. I want to tell you a little bit about the most common brain tumor that I see in my clinic. It's something called a glioblastoma. It's a very malignant neoplasm. It's more than half of all the primary brain tumors that we see. It's cancer for sure. We don't have a cure for it. So our treatment for this disease process focuses on three principles. Number one, making sure we have the correct diagnosis. Number two, maximizing how long somebody is going to survive with this diagnosis. And number three, optimizing their quality of life, all of which we think are equally important. So this is a lady from my clinic from last month, 50-some-year-old lady, otherwise healthy, has a seizure, and then she has this thing. If you ask 10 radiologists, probably 10 of them will tell you, this looks like a glioblastoma. It is in her dominant temporal lobe on the deep side, certainly an eloquent part of her brain. But it turns out what we call glioblastoma is probably a heterogeneous set of tumors. They can have very different behaviors depending on things like genetic mutations. There's one in particular I'm going to focus on. It's an enzyme called isocitrate dehydrogenase, or IDH, and I won't bore you with the biochemistry of it. The important thing to know is that if you have this mutation, it is a good thing. You want to have this mutation because you will live longer. Let me show you how much longer. So these are survival curves. And what you're looking at the top is grade 4, the most aggressive ones, and the bottom are grade 3s. And just by having this one mutation, grade 4s will live twice as long, and grade 3s will live more than 3 times as long. Matter of fact, this mutation we now consider so significant that in the most recent iteration of the World Health Organization guidelines, it is a critical part of the definition for what a glioblastoma is. It's shown in the green boxes here. And they're not uncommon. So on the left is grade 4 tumors, showing you that 1 in 10 patients will have this mutation. And for grade 3s, 3 out of 4 patients will have this mutation. So how do we find out if somebody has it? Well, this is the only way to do it today. It's by taking somebody to surgery and doing either a full resection or a biopsy, and then waiting for a couple of weeks to get the results back. And often by then the story's been told and it's interesting, but it doesn't contribute a whole lot to our decision making. So we wanted to come up with an alternative method that doesn't involve an invasive operation and has the potential to give us immediate feedback, immediate results with regards to this mutation. And the benefit is for somebody like this. This is another patient also from last month. Also ask a radiologist, he or she will tell you this looks like a glioblastoma. It's also in an eloquent part of his brain. And here's the conversation that him and I would have if we knew he didn't have this mutation. In other words, if I knew that no matter what I did or didn't do for him, he's not going to survive for more than 1.5 years. Well, in that case, the two of us are less likely, you could argue, to take on a lot of risk and to cause a deficit from which he's going to have to spend the rest of his life in a nursing home. On the other hand, if I knew and he knew that he had a good mutation, that he has the potential to live for years, then the two of us could take a little bit more risk, would be willing to take on a little bit more risk and potentially cause a deficit that he can go to rehab, get better from, and then spend years enjoying his family. So in order to get to that point, my group, which we call CNOC, and the Department of Neurosurgery at the Brigham collaborated with the Martino Center at the Mass General. And we put together data sets, including our data from Brigham, as well as one other hospital and publicly available data. We basically collected MRIs of patients with brain tumors and then labeled them with the presence or absence of this mutation. The images get pre-processed and then get fed into a convolutional neural network with a simple classifier at the end, basically yes or no, present or absent mutation. And we played with different sequences and different ways of optimizing it. And the bottom line is that we've shown now that on a never-before-seen data set, we can predict this mutation with an error under the curve of 95%, which we think is pretty good. Okay, so for this particular project, we've taken it from concept to model successfully, but I still don't have a tool in my hands to use on my patients. So we are currently actively validating this prospectively and working on creating a front end so this becomes a usable tool. And even though I talked a lot about IDH, it's important to realize that it's one of many clinically relevant mutations in one brain tumor. And there are many other mutations that are meaningful, and there are many other brain tumors. So our goal is to expand this platform and expand it into what we call a virtual biopsy platform, basically taking structural MRI data and then using it to predict not only the biomarker status in a given brain tumor, but ultimately the clinical outcome, and then use that as a decision aid. And I'm going to step back just for a second and tell you a little bit about why I think my field in particular is well suited for machine learning. I've got some biases, as you can imagine. Our patients get MRIs and CAT scans frequently. Matter of fact, if you have a brain tumor, you will get a scan every few weeks to every few months for the rest of your life. And we collect all that data. Every brain tumor that any of us take out ends up getting a whole lot of analysis, including looking for hundreds of genetic mutations in collaboration with Dana-Farber, and that's all being stored. All of our patients spend at least one night, usually more, in the intensive care unit, where we are collecting tremendous amounts of physiological data for clinical use and then archiving it for research. And even when they go home, we are enrolling our patients in the digital phenotyping project, where we are collecting passive and active data about how well they're doing. We think that volumetric analysis is important, so we do that for both malignant and benign brain tumors using automatic segmentation. There's plenty of opportunities to distinguish some very ambiguous lesions, so we're working on that using pathology slides. We want to predict neurological decline before it happens in the ICU, and we use our physiological data to do that. And we want to really take advantage of the EMR data, the unstructured data available, so we build natural language pipelines to do that. And I'm very lucky to be part of a very strong group at Brigham and Women's, again, CNOC. And we also have some fantastic collaborators at the General, in particular, Dr. Kalpathy Kramer and her postdoc Ken Chang were crucial for this project, and many of the other ones that we work on. Thank you very much.